Assalamu alaikum, bismillah ar-Rahman ar-Rahim. I think I'm going to give the talk later on, but I think I've given a talk. My talk again is about perforation, and my disclaimer, I'm a perforator as well. So I'm going to bore you again with another talk of perforation, but I think it's very, very important because when they did a survey, actually, in interventional individuals, especially in CTO operators, what do people fear most while doing the case is a perforation. So let's move on and let's jump. Now, my disclosure, this is my own case. This is not the case that was done somewhere else in which, so this is my own personal case. And I remember it very vividly as it happened yesterday. So this is a 66-year-old, now this is the key, he's a very high-profile individual in the country. So I've been called to take care of him, and I said, sure, we'll take him to the lab. So he had previous PCIs done in his mid-RCA, had restenosis in his RCA, had his RCA had restenosis again with the bare metal and drug-eluting, so a lot of work was done on the RCA. He presented with the unstable angina. And as you see, he had multiple interventions done to that RCA. So we did the diagnostic angiography. The left coronary system was unremarkable. And the right, you can see this instant restenosis in the areas where the stents were placed previously. So we proceeded. We were happy. We proceeded to do the intervention. And at that time, I was very excited about OCT. I still do OCT, but I don't do as much as I used to before because I don't know if Fawaz is here or not. Fawaz he picked up all the OCT. So now if I need to do OCT, I call Fawaz because it takes time. I don't tolerate time. So we did an OCT run. You can see the stent layers, and you have actually new atherosclerosis associated with significant calcium within the stent. And Fawaz is here if he wants to give a comment later on, he could. But that's what it was. So we knew by imaging that there was significant new atherosclerosis with calcification in the previously stented area, with an area possibly double stented, bare metal and drug-eluting. So as you know, is essential, very essential to prepare your lesion before any further intervention. So we utilize, compliant balloons, non-compliant balloons, and this was not giving up. It was still, you had the waist, and we keep on pressing. So then we decided, because we know the size by the IVUS, we decided to perform intravascular lithotripsy, and we used a 4O12 lithotripsy balloon in there. And then, of course, once you use the lithotripsy, it has to be post-dilated further. And actually, I took the OPN. OPN is a double-layered, very, very hard balloon. Double-layered balloon. It is the most non-compliant balloon available on the market. And I used the peripheral inflator, and I went up to 35 atmospheres. And I think this is probably the first thing in the literature which you have OPN rupture. Yeah, so I rupture the OPN. And guess what happens in the lab? Suddenly, I see the guy flat. So, as we discussed earlier, be calm, careful help. I knew what had happened, and the ominous sign is when the patient will say, "Aye," and then it keeps quiet. So, keep that in mind. So if you leave this lecture, if a patient says that there is something wrong had happened, and then what we did is, you can see the perf. I use the acronym BAD, B-A-D, which I'm going to talk about in a second, which is, I always say that to the team. I call my cath lab staff the Mavericks. I inform the Mavericks when I say BAD means balloon and deliver. So meaning I balloon it, control the bleeding, and then you can have a time to breathe a little bit and see what you need to do and to deliver to save the patient. So unfortunately, this was a ruptured balloon, so I could not balloon it, so I had to really get another balloon to go there, and it was an OPN ruptured balloon. So the patient crashed. So quickly, I routinely actually get a second access in my perforations, especially main vessel perforations. I don't do any shortcuts, something I learned after doing more than 14 years of CTO complex procedures. I don't take any more shortcuts. I get it ready so I wouldn't regret it later. So quickly we put a needle in him, we got the pressure back, get the second access, and because I know it will be very, very difficult to deliver the stent graft. But regardless, in my own, as a perforator, I routinely use a second access so that I would not regret and bite my fingers again. So we ballooned it, put a pericardial call for help. Colleagues came in, we put the pericardial drain. Now we can see the balloon is sealing the perforation. The pigtail is removing the blood. I do not, and I will not reverse heparin. I'm going to say it again. I do not, and I will not reverse heparin for two reasons. One is if you fully reverse it and you have a clot in the pericardium, it'll be very, very difficult to remove that. So the blood can clot in the pericardium. Two, later on, if you have a thrombosis in the other vessels, because the patient is hypotension and the perfusion is low, they may actually get clots on the other vessels. So seal the bleeder, do the drain, and think what you need to do next. So we did that. And then that's a ping pong technique that many of my colleagues talked about. And I knew it was going to be difficult to deliver. So I actually used an Amplatz as a guide which is supportive that would be able to deliver the stent graft. So we did that. Patient was hemodynamically stable. And he was still bleeding around it. What I want you to leave, and I think there's another talk, Hein and myself will talk just immediately after this, is what I want you to leave that distal perforations are different, main vessel perforations are different, epicardial perforations are different. The wired distal perforation is a wire perforation, most of the time. Main vessel perforation, we should not call it a perforation, I would call it a rupture. Because you rupture the vessel. And many times, many of my colleagues actually showed that when you put the stent graft, you still bleed. Because it's not a hole, it's a rupture in the vessel. So we actually did the balloon on the inflation on the proximal segment, but why the patient is still bleeding after a stent graft? We put in a 4 millimeter 26 papyrus stent graft, and it's still bleeding. So, pass through that. So there are two reasons. Either the stent graft is not expanded, or you actually did not cover it. So if you look at this, when you perforate, as I say, there are experiments done in the pig heart models in which intentionally inflate, actually you rupture the vessel. So the tear is a longitudinal and serpentinous tear, and typically it happens proximal to the area where you see angiographically the nuclear cloud, I would call it. So most of the time you need to put the stent graft a little bit more proximal if your case was done antegrade. If you're doing the case of retrograde perforation, it has to be distal. So it's not uncommon to see the still bleeding happening, and this is a cartoon which actually depicts for you that the perforation typically is more proximal. So after that, patient was stable. Fawaz was with me, I think. I don't know if he was there or not. But we did an OCT again, and you can see the OCT of the stent graft, and it looked pretty good. Patients stabilized hemodynamically and was monitored. And I actually saw him about a week ago. He still remembers that what I've put in his pericardial drain, but he's doing well. So I'll leave you with this acronym again. It's BAD acronym, balloon and deliver. And thank you very much for your attention.